Good evening, everyone. Welcome to the Tuesday evening webinar tonight. You'll be amazed to hear that this is the 23rd webinar we've done, so I don't know where the time has gone, but we've had a lot of fun during these webinars, so it's a special evening tonight. I would like to introduce Carol Yan of the University of California, San Diego Health. I think that is the name of the medical school. Carol is an otolaryngologist, head and neck surgeon, and assistant professor of surgery. And she will be talking to us this evening about the latest in stem cell research for people who have lost their sense of smell after a viral infection. Also with us tonight, we have Professor Thomas Hummel of the University of Dresden. Thank you so much for coming back, Thomas, after we had a bit of a video disaster last time. So it's lovely to see you again. And Thomas will be talking to us about the latest in a treatment for fantasmia. So that is two really interesting treatments that are going to be available to patients soon. So I'm sure you'll want to hear more about that. We also have with us tonight Aidan Kirkwood, who is going to be managing the Q&A bar. And if you do have questions as we go along, please put them into the Q&A bar, not the chat bar. We use the chat bar, for instance, we're going to put some links in there, which Carol will tell you about. And if we have any other information that we want to put in, we will use the chat bar for that. But if you have questions about what we're talking about now, do please put them in the Q&A bar. Another thing, very often we've got questions about people's individual cases. Of course, we can't really comment on your particular case of smell loss, but if you have general questions, we will try and help you with that. So I think this evening we'll start with Carol. And Carol, I know that several years ago, and I'm just trying to remember what year that was, maybe 2016, 15, 16, there was one article that was published about the use of stem cell or PRP injections, and this created quite a stir. Of course, there was big media interest and great interest in the Facebook group. So I understand that you have been working on this, and so maybe you could tell our listeners a little bit about what's going on with that right now.
Yeah, definitely. Well, thank you so much for having me. It's so great to be here. I'm a huge fan of these webinars and just getting the chance to talk to people about this. I really, first of all, can't take credit for the idea. As you mentioned, Chrissy, this has kind of been a area of research that's been of interest. And in our particular project, as a clinician, the principal investigator of this is actually Dr. Zara Patel, and she's an otolaryngologist at Stanford University. That's where I did my fellowship a couple of years ago. And at that time, we were discussing kind of potentials of novel therapies for smell loss. And it's, you know, Dr. Patel has this clinic, Smell and Taste Center at Stanford, and it was just so frustrating to see our patients just not have any more opportunities for smell loss treatments. And in particular, we're talking about people who have no disease on clinical exam. That's using the nasal endoscopy looking at it. So they don't really have sinus disease associated with this. Right. And so this came up as an idea of using what's called platelet-rich plasma, or PRP, to start to treat the area of the olfactory cleft, kind of that deep in the nose area. And so platelet-rich plasma, or PRP, is actually your own blood. So like if you draw your blood, and it's the plasma portion is the liquid portion of the blood, and it's concentrated with platelets. And so that's actually the mechanism is you actually spin it down to actually get what we call a super therapeutic, really high levels of concentrations of platelets, kind of anywhere between like 5 or 6 times your natural concentration of platelets. And the great thing about platelets is that it's known to have all these biologic supporting tissue regrowth and anti-inflammatory properties. And it's actually been shown to have some data in nerve regeneration. So PRP is actually widely used in other clinical entities. People use it a lot in orthopedics for things like muscle or arthritis or joint pain, and it's helped a lot with the pain aspect. But importantly, they've also used it in carpal tunnel syndrome. And so that is actually related more towards nerves. And so we were interested in kind of looking at, could something like PRP be used in helping regenerate smell nerves, specifically the peripheral nerves that are found inside the nose. So this is kind of, a build on a prelim trial that we saw published, just like you said, Chrissy, years ago. And at that time, they did it, I think, on 5 patients. They said there wasn't much data on this trial. They said they tested PRP, they injected it in the nose 4 times over the course of a few months. And they said that 4 of the 5 patients improved. And so we were kind of hoping to replicate that study initially because we just didn't know at that time, what does that mean to be improved? They didn't really use the same tests that we do as clinicians that are kind of what we would consider the validated smell tests that really show like what level of improvement, what is improved. And so Dr. Patel and I enrolled 10 patients. And this is just, as we kind of mentioned, a very pilot study. This was not a randomized control trial, which are the big clinical trials that are like standard of care. But it was this pilot study of just patients that we knew had tried everything. They had smell loss for at least 6 months, had no signs of sinus disease, nothing in their nose that looked off. Their CAT scans were all normal. And we had them, sorry, go ahead, yeah.
Can I just ask you, these 10 patients, were they post-infectious, or were they a mixture of TBI, and what were the etiologies of that?
Yeah, great question. So the majority of them were post-infectious. So, and this was before COVID-19. So we assumed that they had other different viral infections. But there was, I believe, 2 that were TBI, which is from injury, and then maybe 1 that we couldn't really classify. We would just call idiopathic in the medical field. But basically, we didn't know what caused it. But essentially, all had smell loss for at least 6 months, but importantly, under a year. And the reason we picked this small kind of time period was because our goal was to kind of look at the role of PRP in helping regenerate these peripheral nerves. And the thought is we were going to just pick the most ideal time where there's potential still for nerve regeneration. Not to say that people who have had smell loss for shorter periods of time or longer periods wouldn't benefit from this, but this is kind of, because we don't really know the exact mechanism at this point, we thought would be an optimal people to test it on first. And importantly, we want to make sure we did no harm. And that's like our first goal as clinicians and doctors, is that we don't want to worsen someone's smell loss by kind of sticking needles in the deep inside their nose and putting in treatments. And so that was very reassuring that we saw that of those 10 patients, they all did very well with the procedure itself, and no one had worse smell loss. And that's one of the, I guess, good things about PRP is that it's coming from your own body. So there's no kind of the side effects of medications that we sometimes worry about. Are you going to have an allergic reaction? So because this is your own body's platelets, that this is generally very safe to use. So the worst part of the procedure is actually probably numbing up your nose and having the camera go in and take a look inside, and then getting the needle in, because you actually have to put the, so what we did was you draw the blood. I should go back and kind of explain what the process.
I was going to say, can you walk us through the drawing of the blood, the centrifuging of the blood, what that looks like? How big of a needle do you use? How much PRP, how much plasma is there? So just give us a breakdown of what it would be like if you were sitting in the chair and this was happening to you.
Yeah, for sure. So we get blood from your arm, and honestly, that might be the toughest part of the whole procedure, is getting enough blood. And it's a couple vials of blood, we use 25 milliliters. I think that equates to a few tablespoons. So if you donate blood, certainly that's much less than what you're donating, but it's more than just your average vial of blood to get a blood draw. So once we do that, so there are there's a variety of companies that make our PRP centrifuges and kind of enrichment kits. And so we used one through the AbScents Corporation. And that was just because, honestly, that's what was available in our clinic at the time. So like I said, PRP is widely used in other parts of medicine. Facial plastics is one of the more popular ones that they use. So our facial plastic colleague actually had the centrifuge already and had good results with it. And so we use that. And that's who is working with us currently in our clinical trial. So the idea is that you take their blood and you actually spin it down and through the centrifuge, and you have to buy a centrifuge and specific kits for each patient. This is all sterilized and individualized, so it's packaged. And the spinning process takes, I would say, like 15 minutes, 10-15 minutes. And while that's happening, we are numbing up the nose. And numbing up the nose is kind of like if you've seen any ENT before, when they take a little camera in your nose, it's not comfortable. Now everyone's so familiar with it with COVID. People are swabbing the noses all the time. So if you could imagine that a little bit deeper in the nose, and specifically kind of between your eyes. So we put little cotton balls and pledgets in to really numb it up and make it as comfortable as possible. So that's a little bit uncomfortable. And then when it's all done, we take the 25 mLs of blood and it spins it down to what we ultimately inject, because it's a very small area, is 1 milliliter of PRP on each side. So you have kind of your olfactory cleft on each side. And so the important thing is we still actually have to figure out exactly how much concentration are we injecting. And that's really the big unknown. And that's part of our current study right now, is really quantifying what is that concentration of platelets. It's probably a little bit different from everyone, and we don't know what the optimal concentration is. So there is so much research still to be done for this kind of treatment. But what we went ahead and did was we did 1 milliliter on each side. And the needle is actually quite small. It's like it's like a 20, yeah, it's very small, and it's a 27 gauge if you're in the medical field. But to be honest, that was not the worst part. We asked everyone how they felt afterwards. People did great, and they're numb at the time. So you actually, the part where you actually get the PRP injection, they really couldn't feel it much at all. Afterwards, I'd say most people say that they feel like the little something's in there, like a little full, maybe like needing to blow the nose is probably what most people said. But we actually, thankfully, did not have any kind of complications, no kind of side effects. And so the biggest thing and the most exciting thing is that of these 10 people who had kind of measured smell loss, after trying smell training for 6 months, they tried steroid rinses and still had different levels of smell loss. The ones that at least didn't have the profound smell loss, like absolutely no scent, all of them told us that they improved. So whether that's a placebo effect, just because you've had some therapy, we wanted to test it. So we used actually the smell test developed by Professor Hummel, the sniff and sticks. And that tests their threshold of smell, like at what threshold can you smell something, the discrimination, kind of can you tell the differences between the smell, and then can you identify the smell. And so the people who didn't have profound smell loss actually improved in their ability to smell and had almost a 6-point improvement on these score tests. And that's what we consider a clinically meaningful improvement. So that matches their kind of sensation that they can smell better. The people who had actually profound smell loss, that actually did not show as much of a difference. So whether this is kind of suggesting that you need to have a little bit of smell, a little bit of nerve, regenerative potential there for PRP to improve is kind of what this is suggesting. But again, this is very, very early on data. And so there's a lot to be learned from this.
So the $64,000 question, could this be a promising therapy for people with parosmia?
Yeah, that's a great question, because certainly parosmia is a very, relevant topic, especially with COVID. And it's hard to know because, parosmia at this point, this is targeting what, at least our understanding would be, the peripheral nerves. So in the nose, and parosmia might be a reflection of more of a central nervous system pathway. So if this is truly a nerve regeneration and a disconnect in the parosmia, in the circuitry, let's say, this is actually only targeting the actual first layer of neurons in the nose. So I guess I wouldn't put too much weight in it. And of course, the bottom line is we just need so much more study in the just efficacy of PRP. So I think the important thing is that this was just a very pilot study to assess the safety of it. It was a one-time injection. And so the big questions are, how many injections do we need? Is this a long-lasting effect? What is the optimal platelet concentration? And so this time around, Dr. Patel and I are doing a clinical trial that's enrolling now, that we are looking for a randomized controlled trial. So this is going to be half the people are going to be placebo and half the people are going to be PRP. So it's a little tough to think like, oh my gosh, am I going to get into this and just get saline every time? The reassuring thing is that we think this is safe. It won't worsen your sense of smell. It's a little bit more of a time commitment. Our plan is to do 3 treatments with 2 weeks apart in each. And we will kind of do the same thing, the validated smell test, kind of see how you feel. And then the important thing, I think, with any of these like novel therapies is that it's done in a very monitored setting. And like, I think that's a good thing for clinical trials, is that, we're carefully looking for any complications, any kind of adverse effects of this treatment. And so this will be reported, this will be kind of very full disclosure. So we're not recommending this as like, all ENTs, let's all try this right now. But I think there definitely is a little bit of hope, and also just a lot of room for more research.
So anyone who's listening who might be interested in participating in this trial with Sarah Patel and Carol Yan, when we're going to put the information, the link for that in the chat bar. And just to remind you, if you've got questions to put to either Carol or Thomas in the course of the evening, do please put them in the Q&A feed rather than the chat bar, because we're going to use the chat bar for other things. So Aidan, as soon as Thomas starts talking, maybe you could correspond with Carol in the participants chat section and get the right link, and then put that in the chat so that everyone can see it. So I think that would be great. Now I've got one more question for you, Carol, before we start taking a few questions. And that is, would there be any benefit to injecting different areas of the olfactory epithelium, or is it pretty much just that one small area that you're targeting?
Yeah, that's a great question. So in the nose, the olfactory area epithelium is kind of deep in the middle part of the nose, between your septum, the middle dividing part, and your middle turbinate. And it is that whole little lining. It's like that strip. So during the procedure, we actually do inject like kind of 2 sites, one a little bit up front and then a little bit deeper, as far as deep as we can. At a certain point, you can't inject so many sites because each needle prick probably causes a little bit of trauma, a little bit of bleeding. This is minimal, but so we picked kind of 2 sites in that area. Again, this procedure, this is not something that you should go to your doctor and ask for a PRP injection, so this is only even accessible and visible with a rigid endoscope in the ENT to actually physically go and be able to see it. So it's in general difficult access as it is, but we do generally 2 sites at each point. Yeah, great question.
Good. Okay, thank you very much. Now, I see we've got 8 questions in the feed already. Aidan, could you?
Do you want me to take over? Yeah.
Yes, do ask a few questions.
Sure. We've got a couple of questions here on sort of taste and flavour. And someone asks here, would this therapy also help taste flavour recovery, or was this not researched at the time?
Yeah, that's a great question. You know, I think at this point we're kind of objectively kind of trying to assess the smell, but we certainly think that taste and flavor very much closely links to smell loss. So if you have the candidacy for inclusion in this study would be if you have documented smell loss, regardless if you have loss of taste or smell. So if you think that your taste loss is related to smell loss, then I think this would be an appropriate consideration. And again, at least for our clinical trial at this moment, we're looking for people who, regardless of the cause of smell loss, have lost it for 6 months, who have done smell training, who have done other topical therapies and just haven't had recovery.
Mm-hmm.
Great. Another question?
Sure. Speaking about another therapy someone's talking about here, what about intranasal vitamin A is effective for smell loss recovery? Yeah. Remember, Chrissy's got that on the website about vitamin A, don't you?
I think maybe let's save the discussion for vitamin A for another day. Okay. That would be good.
Sure. And this is obviously still very early days for your research, Carol. But someone's asking, is this treatment permanent or temporary? Obviously, you want to be trying to go for something that is permanent, but
yeah, that's a good question. So at least when we did the follow-up at 1 month, 3 months, and 6 months, we did see kind of a improvement that was sustained over the 1 month and 3 month period. And again, you know, the published study was in the laryngoscope LIO, investigative otolaryngology is the study, and you can see our graphs of how people did, and you can see that they had kind of improvement in their sense of smell that kind of sustained. But also I should mention that when we do the smell testing, the validated testing, we're testing threshold, discrimination and identification, and the majority of improvement actually was seen on threshold. Again, very few patients, but threshold is basically how strong of a smell does it have to be before you can smell it. So people improved on that ability. So that is something we're going to follow up on, especially with this new trial, is kind of how long does it last for. But it did seem to be long lasting enough for 3 months, 6 month follow-up.
Great. Great. Well, thank you very much for that, Carol. I think what we'll do is we'll hold off any more questions for the last 10 minutes of the webinar, but I think right now I'd like to go over to Thomas. And Thomas, you've been doing some research on sodium citrate for fantasmia, I think. So maybe you could start by telling the people in the audience a little bit about fantasmia and what this treatment might be.
Thank you first for the invitation here to the seminar tonight. And nice to hear Carol's talk, so very interesting. And good luck with that research. It's really great. It's the about phantoms. I guess you talked about phantoms in depth already. So most of the time you see phantoms after head trauma. They can occur all the time. So that's one thing. So healthy people, normal people can have phantoms. Interestingly enough, you see it most often in young people and in women more often than in older people and in men. So people are most likely, normal people, to have phantoms as a young woman. So what that means, I don't know really. The question, the idea is that older phantoms, they are somehow related to an intact sense of smell, or like a very vivid imagination that comes with that. So that's part of this story about odor phantoms. Clinically, you see odor phantoms also in all conditions. You see it in chronic rhinosinusitis. You see it most often in head trauma, or often in head trauma. You see it after viral infections. They are also found in schizophrenia and in Parkinson's disease. What's interestingly enough is that they occur relatively more often in head trauma And in head trauma, because they occur together with a lost sense of smell, with an anosmia, the assumption is that it's sort of a decoupling of the central nervous system from the periphery. So normally you have a connection from the nose to your brain to the olfactory bulb, and this connection is broken, and this is then the brain starts acting by itself. This is one of the ideas how odor phantoms would occur. So other ideas about odor phantoms, they come to the nose itself. Actually, Eric Holbrook and Tim Schwab and others published on that you could have like little knots of nerves inside the epithelium, like neuromas, and they start to become spontaneously active for whatever reason. And this is one of the, so there are ideas in all directions. So there are several reasons why you could have an odor phantom. And what we did, we used in our study sodium citrate. Sodium citrate has kind of a funny history. It comes like, was first studied in 2004 by a Greek group, and they tried sodium citrate in a group of patients with olfactory loss and also in healthy people, and found that, or reported that sodium citrate produced almost miraculous increase in olfactory sensitivity. And this never was followed up really. So, and then we tried, we did it in 3 studies, like 2 of them in Dresden and 1 together with Carl Philpott in Norwich. And what we found was that our results were not quite as convincing as the Greek group. So what we had was that when studies were done properly and controlled well, like what Carol was describing with a good olfactory test, then our results were kind of mediocre. So you see something with sodium citrate, it seems to help a little bit, but the results are not really very convincing. It's not like a steroid that people with chronic inflammation take and all of a sudden they can smell. It's not so with steroids. So a certain proportion of people can increase their olfactory function. As a side effect of one of these studies, we found that sodium citrate was very successful in odor phantoms. So we had approximately 20 patients in one group, and they all had odor phantoms. This was a mixed group. Most of them were post-viral, so they had olfactory loss after an infection of the upper respiratory tract of the nose. And we found that out of these 20, 17 improved in terms of their odor phantoms. So that was quite spectacular. And this is what we published last year together with Katie Whitcroft. And now we are about to follow this up in a large group of people that are more defined. The thing is with odor phantoms and with parosmias is that they're really difficult to measure. So you need large groups. If you see anything, you can do function imaging, or one can do event-related potentials. So there are some possibilities, but typically to see an effect, you need to have large groups to see these effects on olfactory function. And this is what we are planning to do. Currently, well, the study that we published stands is that we asked people about their odor phantoms and they improved. So people told us that their odor phantoms were gone after this. So this was quite, in a way, it sounds very convincing. In some way, it isn't, because odor phantoms, they're very much due to suggestion also to some degree. So some people really have bad very odor phantoms. They might argue with me now, but clinically, you see that in many cases, people are suggestible on that. So if you're distracted, the odor phantoms are gone, or if people eat something, the odor phantoms are decreased. There's one study by Dr. Hankin in Washington, and he tried odor phantoms with a transmagnetic stimulation and also had an effect on odor phantoms. Although really, when you look at the technology, it's kind of problematic to imagine that the magnetic stimulation really targeted the centers that could be responsible for the odor phantoms. But of course, you have the treatment, they come with a loud noise, this all together is a strong placebo effect. This is what I'm saying here. So we find an effect which is highly significant, it's all there, it's a fairly controlled study, except that we don't have that it's difficult to measure, but a portion of that could also be placebo. And this is what needs to be checked in future studies.
And Thomas, do you think that there are different kinds of phantasmia? So that the phantasmia that's experienced by the person who is recovering from COVID-19, profound smell loss as a result of COVID-19, many of those people report phantasmia. Is that a different kind of, will there be a different, I don't know, mechanism behind that as behind someone who has idiopathic phantasmia out of the blue without any, you know, cold or anything like that? So do you think that these phantasmias are different? And do you think that application of sodium citrate might work for some kinds of phantasmia, but not others?
Yeah, that's a very good question. And I think you're touching on a very important point here, that what we clinically see is often like it's smell loss, like these are distorted odors, these are odor phantoms, but the story behind that may be very different. So phenomenologically, what people tell us and what people experience, that may all sort of look similar, but the reasons for that may be very different. This is what I pointed out, like with the odor phantoms, that you have so many different reasons. As I said, you know, healthy people can have it. Like the cause could be at the level of the nose, it could be at the level of the olfactory bulb. Actually, people with an odor phantom, they seem to have smaller olfactory bulbs than other people. So maybe that's pointing towards a decreased inhibition of signals. And then you can have it at the brain level. People with migraine have odor phantoms, you know, or like people with epilepsy or people with schizophrenia. So all kind of different brain areas might also be involved to produce the same symptom, odor phantom. So exactly what you say, there may be different causes that may clinically shine up in the same way, but they might respond differently to treatment. So only a certain group of people might respond to sodium citrate. For them, it might be the right medication. For others, it might be totally wrong. And so this needs to be sorted out. And I guess that relates to much of what we see clinically in terms of smell loss. You know, it all people present with smell loss, but the reasons for that may be very different, and also the treatment should be different. So this is what brings us back to diagnostics. So that's what medicine is. Like medicine is all about diagnostics. So if you have, the better the diagnosis is, the better the treatment can become. And I guess this is also what Carol was saying. So it's work in progress. So we're working on that. And sometimes the medication helps us to find out about the different causes, because what you say, Chrissy, exactly, in some people it might be helpful, in others not. So in some people where it helps, it may be one cause, and in other people where it doesn't help, might be a very different cause.
Right. Very interesting. And I think sodium citrate is a very benign substance that you can buy over the counter. Isn't that correct?
Well, basically, yes, it's like lemon juice. So
right.
You dilute it a little bit, and then it's all of a sudden it becomes sodium citrate in a diluted form.
Right, right. And I mean,
I would not recommend to put lemon juice into your nose, you know.
Good. I was going to say, you know, and of course there are a lot of desperate people out there who are trying to find solutions to their problems. And, you know, I'm hoping that you will caution people against perhaps going on to Amazon and buying sodium citrate and sort of, you know, piling it into their noses. I think, you know, in all things, caution is to be advised.
Yeah, I was just trying to emphasize the low toxicity of the therapy. So it's basically it's citric acid, like you find it everywhere in the body. Also, it's in a diluted form. So don't put lemon juice into your nose. It might be a bad idea. You may produce an inflammation there. So it should be diluted, should be applied in a certain position, that you lie on the side, you tilt your head, you apply a little bit, a certain amount of the citric acid in this diluted form into your nasal cavity. You have to lie still for some time. And then, so the citric acid would reach the olfactory epithelium. And then this needs to be repeated over a certain period of time, a couple of days. And then it seems to have an effect there. But I think I would strongly, as you were saying, I would strongly advise to buy lemon juice and put it into your nasal cavity. But it's on the same side, it's also not very dangerous to do it. Actually, we had apart from slight irritation, we had no side effects in that study.
Good. Okay. So I'm sure that that is going to generate a lot of questions. So what shall we, let's see.
Do you mind if I ask a question?
Please, Carol, go ahead.
I've been wondering, Professor Hummel, that you had said, I think you just touched upon it actually, the way you spray the sodium citrate into the nose is very important, because most nasal sprays, as we tell our patients, you know, they don't reach all the way up high to the olfactory cleft. And I think, can you just go in a little more detail that you actually have everyone lay back and tilt their head a certain position to get it into that region?
Yeah, that's a tricky bit also when you have a spray, and as you were saying, when you spray something in the nasal cavity, most of the spray is ending up here in the anterior portion of the nasal cavity. And if you really want to get it up to the olfactory cells, it needs to get between the eyes more or less. So it's very deep inside your nose. And to reach it with a spray, you need what we try there. You need to have a certain adapter for that. So with like a long nozzle that goes deep inside the, well, about that deep into the nose. And then you can reach the olfactory epithelium to some degree, so where the olfactory receptors are. With the drops, it's a little bit more, it's even easier, but you have to lie on the side. So you lie on the side, tilt your head, and then you drop from the top on your nasal septum. So on the middle of your nose, you stay there for like half a minute and wait until it reaches the olfactory cleft. So we tried that with dye, with color, and verify that it's really getting there. This is one way to do it. So even people who are a bit frail, you know, not so agile, they still can do it. So they can lie on the side and watch TV at the same time and put the drop into your nasal cavity.
Just incidentally, we made a video on using the Kaitecki method. Simon demonstrated ably with our cameraman, and so anyone that is watching this and who wants to know more about this technique for applying drops, Aidan will shortly be putting a URL link into the chat bar so that you can find out how to do that. And I agree, it's not the easiest thing to do. And once you get it right and you know exactly why you're holding your head at that angle, and it all makes sense and it works really well. So yes. Oh, and there we go. Thank you, Aidan. Thank you.
You're welcome. We have a question here saying, I wonder if both Dr. Jan and Professor Hummel, if the COVID-19 pandemic has had an effect on the research. For example, more patients available to participate, or an influence on the kind of areas being researched?
Interesting question.
Yeah, I would say absolutely. If anything, you know, I think we have so much to thank for our patients who have really spurred on this research interest. It's really brought together just world-class researchers that I've just been fortunate to even meet virtually and talk to and learn about each other's research has been really cool. But actually just we're so thankful for how much you guys share with us. And your experiences really drive our questions, and absolutely from the actual government standpoint, at least speaking from the US, the NIH has shown much more interest in funding research in smell loss. It was always an area that was understudied and you know, one that didn't have as much of a group together to study it. But now I think, you know, they like to say everyone is jumping on board. So I think that's really exciting. It'll build a much better platform for future clinical discoveries, hopefully.
Mm-hmm.
Yeah, just can emphasize that. I think also it has done a lot. It changed the view of the world on the sense of smell, that it's actually not an unimportant sense. It also actually it spurred some really interesting, great research in the sense of smell. And there was a nice paper, Stuart Firestein was involved in that, on receptor expression at the level of the olfactory epithelium during an infection of the olfactory receptors. And obviously, you don't express that much receptors. So the cells are still there, and the number of receptors that are being expressed on the surface of the cells, that are being, so the antenna of the cells, they are being pulled back inside the cell. They are no longer expressed there. And this type of research, this is only has become possible through the COVID-19 pandemic. Before, nobody had the interest in it. And it's also due, of course, as Carol was saying, it's due to the interest of patients also in that, and to the help from that side. Also, what you are doing is just fabulous. It's very nice.
Yeah, and I think one of the biggest things for COVID-19 is that we actually have now a time frame of when people got infected, and we actually know that there's a specific virus involved. A lot of times for people who have had smell loss, we think it's virus. I think you had a cold at some point, but we're not sure. It could have been last year, it could have been 5 years ago, and now with so much just the prevalence of viral testing, and we know like exactly the day you lost your smell, the day what virus caused it, and that's really helpful in actually kind of more definitively saying like these are the causes and what can we do about it. So
I think it's also helping people come forward, because now they have a name to things. They know what parosmia is with the name. They know what phantasmia. So I think having the description, that in our dictionaries, we know where to go about it these days, which I think helps on AbScents site.
Yeah, I mean, certainly when I think back to what the Facebook group was like before COVID, people might find us a couple of months after they lost their sense of smell, or even years. They would somehow learn what the word was, and therefore in searching on Facebook, they would find the group that way. Now, what's remarkable is that we have people coming into the group who will say, I lost my sense of smell yesterday. Mm-hmm. Now, that would never have happened before, because this is, the anosmia is on everyone's lips. Everyone's seen it in the newspaper. Everyone knows what the word parosmia is now, which is to me even more unbelievable, that this thing that used to be a sort of niche, that those of us who had it suffered in terrible silence with it, that now, everyone knows about it, everyone's asking about it. And, this is as tragic as the whole pandemic is. This will help us a lot in the long run. And Carol, what you say is quite right. We have this huge bulge of people who lost their sense of smell in March. And of course, there have been other sort of, peaks, but nothing like the peak that we had in March. So that cohort is an interesting one.
Professor Hummel, someone says here, is sodium citrate nasal spray available to purchase anywhere, or is it still in trials? I think you spoke about the whole lemon thing there for a second as well.
Yeah, it's not available in pharmacies, so we use it in our study, and our pharmacy they have a special license to do it, and then they did it for us. So, but it's not commercially available, and we don't sell it because we are not a drug company, so that's why. But if you have a doctor or you have no pharmacist, so basically everybody can make that, so it's not a big deal. But you probably need somebody to control it. That would be advisable, and I would not do it by myself. I would do it with a controlled fashion, see an ENT doctor, and so who can help you in applying this.
Yeah, absolutely. And as an ENT, I know that it's not very familiar for most ENTs. I think this is still kind of very new research, but I know in the US, we are able to prescribe it for our patients through compounding pharmacies. There's certain ones that are more familiar with nasal sprays and products that are, and so much of it is the drug delivery. So you want to make sure you're doing it the right way. You want to make sure you have the right type of spray or drop that will get it there, because it's not just about kind of putting it in your nose anywhere. So.
Mm-hmm. Good. In fact, actually, I was talking to someone who is an asthma specialist, and they were saying that, the many ways that patients get the use of their products, of their medications wrong, because they're used in the wrong way, they're aimed the wrong way, and so on, that it is a real problem. So getting it used correctly is obviously very important. Good. Okay, so any more interesting questions? How are we?
So, got a question here about different types of scans, but we spoke about that before, that you can't really see on a cellular level the sort of mechanisms of things. I think Simon spoke that about in a previous lecture. And I don't think MRIs or things are involved in any of the studies spoken today. I don't believe so, were they?
It might be, I mean, I'm asked this a lot. This comes up a lot also in the Facebook group. And so while I have you both here, Carol and Thomas, would you mind saying something about to what extent the damage that has been done by COVID-19 can be imaged? It's my understanding that these are things that are so small that you cannot see them on any MRI scan or any. There's no way of determining exactly at what level the problem has happened. Can you say anything about that? Is that a correct assumption, or is that incorrect?
Well, it's the virus itself is too small, of course, but what you can see in MR imaging, you can see like effects of the virus on the brain, for instance, when it comes through, probably through the vessels into the brain, and changes like vasculature of the brain of certain areas. Then what you can see is lesions there, or you can see long-term effects of this. So you can see when there's an edema or where there's an acute inflammation in the brain. This is what has been imaged also, and also will be. This is what you can see. So if I would have an acute brain infection, I put myself into the scanner, my brain would look different from other brains, so from before and after. So this could be seen. In the long term, what I could see is also that the volume of certain areas of the brain is changing, like the olfactory bulb volume becomes smaller or may become larger. These are effects that can be seen. One can also see like responsiveness of certain brain areas to olfactory stimuli. Like you can see whether the putamen is activated by odors, or the amygdalae are differently activated. This all can be seen, and this is very interesting to study. On an individual level, it's kind of more problematic. So what you can see there is like acute infections, if they're relatively large, or you can see like changes in volume. Individually using functional scans, it's kind of problematic. So because it's too noisy.
And Thomas, am I right to think that an fMRI scan is not the sort of thing that you would get at your local ENT clinic? I mean, you are in a specialized clinic where you have all the diagnostic procedures available to you, but for someone who is sitting at home, who has had smell loss from COVID-19, maybe has parosmia, those kind of images are not necessarily going to help them. Is that correct?
Yeah, it's one thing that they probably do not provide clarity, because these are very noisy measures, because the brain is always the entire brain is talking to each other all the time. And when you apply an odor stimulus and you perceive like a very strong smell of rotten eggs, then it produces in your brain in some areas some changes in blood flow that are about, if you're very lucky, they're like 5% above the noise. So you have 100% noise in the signal is then 105%. So it's not much. And at the same time, you have all kind of other influences. So on an individual basis, if I would do it on myself, I probably don't see anything. So it's not very helpful there. So it's if it might be offered locally at some clinics that they offer some function imaging, but I would doubt there's no published proof that on an individual level this would be helpful. Let's put it that way. It doesn't mean that structure, if you look at the brain itself or with different tools, this might be helpful. If you have a tumor or an inflammation, this can be extremely helpful to look at that. But like applying an odor and seeing what the odor does on terms of activation in your brain on a single individual, this probably is very difficult to judge. Very difficult to tell whether this is useful. So I would say not.
Right, right.
So, yeah, I was going to say, sorry, Thomas, Professor Hummel. So, are you saying that if someone shows any other sort of clinical symptoms of suggesting something else, that's when MRI and things are used, as opposed to just olfactory loss? Is that what you're getting at?
No, I'm not saying just olfactory loss. Olfactory loss can be a very strong symptom of something, and MRI can be very useful to look at that. But what Chrissy was asking about functional imaging, and functional imaging is probably not. So there's difference in structure and function. You know, if you look at your brain and look at the different structures of your brain, then you can be very detailed. You can learn a lot from that. So you can have different types of images. You can see where's an inflammation there or not. But what Chrissy was referring to was functional imaging. If you apply an odor in certain areas sort of being activated, this is good on a group level. If you have like 20 people to study or 30 people, you can also learn much from that. But individually, I would say no, not now.
Yeah.
Yeah, we've got a question here. Professor Hummel, you mentioned suggestibility regarding phantosmia. Is there work done in terms of behavioral or CBT strategies to help with this condition?
That's a very good question. And although it's so suggestible, I'm not aware of any good study, or not, these are maybe anecdotally it has been done, but you could think of many different things, you know, psychotherapy, you could think of hypnosis even, you know, but this hasn't been tried. So it's would be really interesting to study that in people with a long-term phantom that is really bothering them. So this might be a good way to approach it, to go to a psychotherapist who could help you in that way to better deal with that symptom.
Yeah. Of course, if anyone is struggling, it's important to reach out to someone like that.
And I think, you know, Chrissy, you and Jane Parker were talking about this at your previous webinars, is just kind of one of the best things to do for phantasmias is to power through it. And for parosmias is to really try to force yourself to overcome these really kind of malodorous smells and in kind of in those, you had mentioned really great, like that, you know, you had done so yourself and kind of was able to overcome some of the smell that was most bothersome. So I think that kind of speaks to what is maybe more formalized through cognitive behavioral therapy.
Yeah, that certainly, when it comes to eating, and you're confronted with a food that you just think you just can't eat. What's interesting is that it's the first couple of mouthfuls, and then suddenly you seem to be, you've stepped over the barrier. And it may not be great, but you have passed that really, those terrible first few moments. So yeah, we do recommend that. Obviously, not everyone can do that. And for the poor people who really have parosmia to such an extent that they, you know, are vomiting, that's just not an option. So hopefully that phase won't last too long for them. It's true. That's very problematic.
Someone's saying here, if PRP has worked for something else like tennis elbow, is the chances that PRP for smell loss will work?
You know, I think it might just be a separate mechanism. So certainly, not to say that that means you are PRP susceptible. You know, that doesn't mean that PRP will work for you all the time. In fact, with the tennis elbow and a lot of the joint pain, it might be more of an anti-inflammatory property in the platelets. And in like we were mentioning on the MRIs, sometimes with smell loss, it's not at least a visible inflammation that we see on imaging on MRI. So it might just be more of a nerve regenerative property that we're hoping to generate with the platelets. So, you know, it could or could not, but it's not saying that you are particularly going to benefit or not benefit from PRP.
Right. Okay, so let's see, we still have, there's a question here from Glennis Scadding, one of your colleagues in ENT. And she's asked, if you're making the olfactory epithelium bleed, then there will be plasma there. So a placebo group is vital.
Absolutely, yeah. That's exactly what we're hoping to kind of compare to this time, because it is so many of therapies, especially if you really want something to help, just doing something is a great process already. And so, we definitely want to see the saline group. We're going to inject, the placebo will be an injection with saline versus of PRP.
Yeah, someone else is asking here if they have a link to the Firestein study. Was that Professor Hummel's one? Was that Firestein? Is the name Firestein on?
Yes, the Stuart Firestein was part of the publication, and I don't know who's the first author. It sounds, I think it is like a.
I think I have the article on my desk.
I have it also on my desk in my clinic, but I don't have it here. So, but if you look for Firestein S in PubMed, you will get the latest publication of his. So he's in the middle range of the authors. But he's
I think you're talking about, is this a preprint from medRxiv? Yeah, it's from the Lombardis lab at Columbia, and the first author is Mariana, but I would the senior author would be Jonathan Overdevest and Stavros Lombardis. And it's a recent preprint, it's a nicely done study with really great molecular research looking at autopsies who from COVID-19 tissue. Is probably the largest set of olfactory tissues from COVID-19 patients collected, and they looked at in the humans as well as in hamster models who have had COVID-19, and they looked at from the cell and molecular pathways which receptor kind of the downregulations of olfactory receptors as a mechanism for the smell loss. So I believe Stavros Lombardis and Stuart Firestein and Jonathan Overdevest preprint. So.
I have a quick question about sort of the both of your research in terms of over time these things can improve. So how would you know in terms of your treatment and things that this was definitely from treatment as opposed as I guess that would be what a placebo is. That's the best of the question. But yeah, because obviously time is a healer for some people.
Exactly, completely agree. And with post-viral smell loss, as I think Dr. Hummel's research previously showed, we can get improvement up to 2 years. And so that's why I tell all my COVID-19 patients that this virus is still so young and the smell loss is still so new that certainly there's still a lot of room for improvement on its own, even if you did absolutely nothing. So for at least PRP, placebo group is going to be of paramount.
Yes, for everything, for every study that you do. I mean, I guess that's one of the reasons why there's also, regardless what you do, if you hit people on the foot for 14 days in a row, you will see improvement, because there's spontaneous recovery in people, and you need a control group where people have not been hit on the foot. So that's why this would show you the difference.
Not that we're implying that gets done.
Yeah. Good. All right. Well, I think as we're sort of approaching the end, if we have a couple of other questions, we might try and squeeze them in. But while we're waiting for you to get your last minute question in, I can tell you that in 2 weeks, I will be back here again with Professor Barry Smith, and we will be talking about smell, taste, and flavor. And this is always of great interest to people, especially in the COVID-19 group, because many of them report that they have, while they can smell things through their nostrils, they are not able to perceive flavor through the retronasal pathway. So we'll be talking about that a little bit, doing some experiments, I hope, and inviting people who are in the audience to join us in that. So do put that in your calendar. As always, the webinars are free and we have them stored on our YouTube channel. So now we're getting on to 23 hours worth of videos that you can catch up
Might need to do like a marathon of AbScent. We'll need to do that, Chrissy, won't we?
Imagine it. Binging the series.
Yeah, there we go.
So are there any, do we even have one more quick question at the end? Does a neti pot help? Lou, I would say a neti pot is always a good idea, although I'm in favor of nasal rinse bottles, but I don't know. Thomas and Carol, what do you think? Are you nasal rinse bottle fans or neti pot fans?
I am a nasal rinse bottle fan.
So Simon.
Yeah, me too. Me too. Right. I think that's what we have time for. So it's been a great pleasure having you, Thomas and Carol. Maybe we'll see you again sometime. Thank you to everyone in the audience. I know that that Aiden is going to, capture the chat bar and all the other information about tonight. If you'd like to get in touch because you missed something or you wanted a link or need any other information, you know where to find me. And so I'll see you in 2 weeks. Good night, everyone. Thanks very much.
Good night. Thank you. Cheers.
Thanks very much.